Hello everyone. Welcome to the e-learning course on rational use of medicines. And today, as part of the e-learning course, I would be covering the topic Essential Drug List, National List of Essential Medicines, and the WHO AWaRe classification, which is the part of our WHO model list of essential medicines. So I really hope that you find the presentation useful and you are able to understand the key concepts of essential medicines, how the national list of essential medicines is formulated, and the latest updates of WHO in the WHO model list of essential medicines. I'm Dr. Madhur Gupta. I'm the Technical Officer Pharmaceuticals working in the WHO India Country Office in New Delhi, India. So, as we know that irrational use of medicines is a global concern and it is a major problem worldwide. WHO actually estimates that more than half of all the medicines being used all over the world are prescribed, dispensed, or sold inappropriately. And actually, more than half of the patients fail to take them correctly. So, patient compliance is also a big issue that is a global concern which the world is facing. And this leads to actually a lot of overuse, underuse, misuse of medicines, including antibiotics, and which results in wastage of very precious resources of the health system. Some of the examples which I would like to give is, polypharmacy, use of too many medicines per patient by the doctors, or inappropriate use of antimicrobials, not completing the antibiotic course, using an inadequate dosage for non-bacterial infections, not completing the course. Overuse of injections is another problem. Non-compliance of the patients with the antibiotic therapy, the complete course, and non-compliance with guidelines, clinical guidelines. You would know that there are standard treatment guidelines which the doctors and clinicians have to adhere to. So, failure to prescribe in accordance with these clinical guidelines, the standard treatment guidelines, are some of the examples. Non adherence to the dose prescribed. If, for example, it is prescribed twice a day and the patient takes only once a day. And it is also seen these days, many patients are using antibiotics on their own, inappropriate self medication, using it, learning it online, or using online resources to self medicate is again a major growing problem which the world is facing, especially with prescription only medicines. And this irrational use of medicines has massive detrimental effects and leads to, actually a delay in the patient getting the cure from the disease. It may also lead to a lot of adverse drug effects, or if the patient is hospitalized, prolonging the hospitalization. And the major issue which is being seen as a consequence of this irrational use of medicines is antimicrobial resistance. We are seeing a huge increase in antimicrobial resistance in the Indian patients uh, because of a number of these issues of irrational use of medicines, causing financial losses to patients, decreased, increased morbidity, mortality, increased microbial resistance, and increase in prescribing and dispensing errors as well. So let us come to the definition of what exactly is rational use of medicines and how WHO, World Health Organization, actually looks at it. The WHO has defined rational use of drugs as per the definition which you see on the screen. The rational use of drugs actually means that patients receive medications appropriate to their clinical needs and also in doses which meet their own individual requirements for an adequate amount of time and at the lowest cost to them and the community. So you see, all these points actually are key aspects of rational use of medicines. It should be the correct drug, it should be given for the appropriate indication, it should be prescribed considering the efficacy, safety, suitability for the patient, and the cost aspects as well. So, affordability and the cost of the drug is very much a part of the definition which WHO has prescribed. It should be given in appropriate dosage, administration, duration, in correct dispensing, and the patient should adhere to the treatment. So, patient compliance is extremely important. So, what are these essential medicines? These are broadly described as those medicines that satisfy the primary health needs of the population. They should be available at all times within the context of functioning health systems in adequate amounts in the appropriate dosage forms with assured quality and an affordable price for an individual or health system at large, that means the community at large. And these essential medicines are selected by member states or countries with due regard to the disease prevalence, evidence of safety, efficacy, and quality, and comparative cost effectiveness. WHO actually has been working in the area of essential drugs and development of WHO model list of essential medicines since 1975, since the 28th World Health Assembly. There was a report which led to a resolution in the World Health Assembly requesting advice on selection, procurement of essential drugs of established quality corresponding to the national needs. And in 1977, the first model list of WHO was published. It had 200 plus active substances. And since 1977, WHO has been very actively publishing this list every 2 years once it is ratified by the WHO expert committee. The 2002 revised procedures were then approved by WHO, and currently the list which you see on the website of WHO is the 22nd WHO Essential Medicines list and the 8th WHO Essential Medicines list for children. And these lists have been updated in 2021 for all the countries to use. So you see here the first one, the technical report series, which brought out the selection of essential drugs. So this is the website, how it looks, and the 22nd model list of essential medicines ratified by the WHO expert committee on the selection and use of essential medicines. So these lists are available to member countries to adapt to their own settings. This is a model list which is prescribed by WHO for adaptation to be done in countries. The countries have to look at the disease prevalence which is present in their countries and the availability of the medicines in their countries and refer to the WHO list and adapt it based on their settings, their disease prevalence, and their situations. So the adult list is available as well as the children list is available. And it is quite an exhaustive procedure which WHO follows to, bring out the WHO model list of essential medicines. There are several departments which collaborate, and there are clusters and in WHO which collaborate with the WHO Essential Drugs and Medicines Department. There is a collaboration which happens with the WHO model formulary. It is referred to. All the clinical guidelines of WHO are referred to while the WHO Essential Medicines list is formulated. There is also a linkage with the other agencies such as MSH, UNICEF, MSF, and also with the statistics department and the international pharmacopoeia reference standards. There's a whole lot of gamut of areas which contribute for the development of the WHO list of essential medicines. So WHO EML is a comprehensive and freely accessible online database which you all can refer to. It contains information on essential medicines. And recently, this is an electronic form of the WHO's model list of essential medicines. It is freely searchable, and you can see here on the screen that you can filter, the drugs you can see, but you can also filter by indications and target populations and sex also, and try to search whatever medicine you are searching. And once you click on these medicines, the complete recommendation emerges on the screen. This is for 591 medicines and 124 therapeutic equivalents. The WHO Global Essential Medicines List is a database of essential medicines list for 137 countries based on the WHO's National Essential Medicines List repository. And this is how the website looks. The Global Essential Medicines List, if you search India in the list, you can actually compare the Indian list with the WHO list. And as you see on the screen, the compatibility is quite high. It is 65% compatible with the WHO list of essential medicines. And there are, in the Indian list, there are 367 medicines in the list. And there are about 303 differences from the WHO model list. So you can actually compare and see with different countries how different countries' list looks like vis-a-vis the WHO model list of essential medicines. So in 2021, I wanted to touch upon this in little detail because this is a very important concept. The AWaRe classification was introduced in the 20th model list of essential medicines. And as part of this, for the first time in the WHO's list, the concept of access, watch, and reserve antibiotics was introduced as part of the WHO model list. So this is basically required, the awareness of this is important because of the global recognition of the need for effective antimicrobial stewardship, as well as the need to ensure access to necessary antibiotics, appropriate prescribing, and understanding of the standard treatment guidelines, etc. So this new categorization has been divided into three groups: access, watch, and reserve. The access group comprises of the first and second choice antibiotics for the empiric treatment of most common infectious syndromes. So these are those antibiotics which should be available at all times in the health system. The watch antibiotics have a higher resistance potential and whose use as first and second choice treatment should be actually limited to a smaller number of patient groups, smaller number of syndromes. And the reserve antibiotics should be used mainly as the last resort treatment options. So these are those drugs which are the most high-end antibiotics, and we have to preserve them as a last resort for the treatment of patients. So this classification was developed since 2017 by the WHO Expert Committee on Selection and Use of Essential Medicines as a tool to support antibiotic stewardship efforts at local, national, and global levels. And it's a very useful tool because the countries are using it now to adapt their own national lists using this concept of AWaRe classification of antibiotics. So the 2020 to 2021 update of the AWaRe classification actually includes an additional around 78 antibiotics which were not previously classified. So there is a total of now 258 antibiotics. The access group, coming to now the details of all these three groups, what these groups are, what are the antibiotics they contain. The access group actually includes antibiotics which are recommended as empiric or the first or second choice treatment options for common syndromes. And they should be widely available at an affordable cost of assured quality. The first choices are usually narrow spectrum agents with positive benefit to risk ratio and low resistance potential. Whereas the second choices are generally broader spectrum antibiotics with higher resistance potential or less favorable benefit to risk ratios. These antibiotics in the access group are recommended only for a limited a number of indications. And for the antibiotics which have the potential for more resistance, they are listed in the watch group and the reserve group. So this is what the access group looks like. You can see our simpler antibiotics, amikacin, gentamicin, amoxicillin clavulanic acid, the imidazoles, the penicillins, the sulfonamides, and tetracyclines are part of this group, the access group, which should be freely available in the health system and at affordable cost. Coming to the watch group. The watch group includes antibiotic classes which generally have a slightly higher resistance potential but are still recommended as first or second choice treatments, but for a limited number of indications. These medicines should be prescribed, when uh, there is a need to prescribe them, and the indication or the syndrome requires a higher level of antibiotic to be given. The group also includes the highest priority agents on the list of critically important antimicrobials for human medicine. You can see here these include fourth generation cephalosporins, our fluoroquinolones, aminoglycosides, the lincosamides, macrolides, and some of our antibiotics which are very precious to us, the third generation cephalosporins, the streptogramins, rifamycins, quinolones, etc., are part of the watch group now. Coming to the last reserve group, which is the last resort category of antibiotics prescribed by WHO in the WHO AWaRe classification. These antibiotics should be treated as the last resort options and tailored to highly specific patients or highly specific settings where everything else has failed. And if we don't give this antibiotic, we have nothing else to give. So extremely serious life threatening infections, cases of sepsis, etc., those are the categories in which these antibiotics should be used. So this is the category of reserve group. You can see here the polymyxins, the colistin, our third generation cephalosporins, the oxazolidinones, monobactams, the fifth generation cephalosporins, they are all part of, and the carbapenems, which are extremely important, part of the reserve group. We also have a WHO AWaRe antibiotic book 2022, which has been released recently as an adjunct to the WHO Essential Medicine list. And this provides concise evidence based guidance for more than 30 clinical infections in children and adults. So, this again is being used by policymakers and by pharmacists, by hospitals, primary healthcare settings, etc., as a guidance when not to use antibiotics. And I'll highlight some of the key messages which are there in this antibiotic book. This is available online for a free download. No antibiotic care, safely reducing antibiotic use. So mostly, healthy patients with mild common infections can be treated without antibiotics. So the doctors have to be watchful and careful when they are treating patients, that if the condition requires no antibiotics, then they should not prescribe the antibiotics. So the first message, as I mentioned, is no antibiotic care, and if the treatment can be given without antibiotics, the doctors should actually favor that approach in conditions which do not require antibiotics. The second major key message which I want to highlight is that a large majority of common infections can be treated again without any antibiotics or with minimal use of antibiotics with our access group of antibiotics. This will avoid the arsenal of the watch and reserve group of antibiotics to be used inappropriately, and that this approach will reduce the inappropriate use of watch antibiotics. So improving access to antibiotics is the first approach, and using the appropriate antibiotic for the appropriate condition and using the antibiotic only when necessary. Preserving the watch group and the reserve group of antibiotics. That is how the clinicians and the healthcare professionals should actually prescribe antibiotics. We also need to reduce the use of not recommended antibiotics. WHO has developed a list of fixed dose combinations of antibiotics whose use is strongly discouraged. You can see this list. I have also put the link of this list here, which you can also refer to. And we have to educate and make the prescribers more aware of all these concepts. Improving awareness is the key message here. All prescribers, dispensers have a responsibility to improve the use of antibiotics. And patients should also be made more aware that they have the responsibility to not, ask for antibiotics when it is not required. Many of our, primary healthcare providers sometimes are pressurized or they are asked to prescribe antibiotics sometimes by uh, patients who have read it online or who have little knowledge, and they feel that they will get better only with an antibiotic. So patients also have responsibilities and have to make those efforts. The antibiotics should be prescribed appropriately in appropriate dosage and for the appropriate duration. Now, coming to the national efforts and the national list of essential medicines 2022. Government of India, Ministry of Health and Family Welfare, through the Standing National Committee, has been revising the national list of essential medicines in India. And these medicines have been categorized in 27 different categories. The latest national list of essential medicines for India was released in 2022, and this includes about 384 drugs which have been included in this list. About 26 drugs have also been deleted from the list based on the current situation of the disease prevalence, the need for adding more lists, the antibiotic resistant data, and a number of other factors which the committee looks at when they are developing the national list of essential medicines. The primary purpose of the list is to actually considering the three important aspects: the safety, the efficacy, and the cost of these drugs. When you refer to the national list of essential medicines, you will see these small symbols within the list: P for primary, S for secondary, and T for tertiary. And these are some of the criteria for any country, but India has basically looked at these criteria for inclusion in the national list of essential medicines. The drugs which have been included are for the public health problems in India. Those have been approved by the Drugs Controller General of India. They have proven efficacy and safety profiles. So these are the drugs which the disease prevalence in the country requires, and these drugs are comparatively cost effective. They are also aligned with the current treatment guidelines, for example, of tuberculosis, HIV, malaria, and other national health programs of India, like ivermectin is part of the accelerated plan for elimination of lymphatic filariasis. And the committee has also been careful to include one prototype medicine from each therapeutic class. The price of the total treatment has also been considered. The fixed dose combinations are usually not included, and some of the vaccines, such as the rotavirus vaccine, which is an important vaccine for the universal immunization program, has been included in the India list. This again, the WHO model formulary, it is a very important source of independent information on essential medicines for prescribers worldwide. The first model formulary was launched in September 2022. Again, this model formulary of WHO is freely downloadable from the website, and it is periodically updated by WHO. The Government of India has also launched the National Formulary of India. It is periodically updated, and the last version, the sixth edition of the National Formulary of India, was published by Indian Pharmacopoeia Commission in 2021. The main objective of the formulary in India is to promote rational use of medicines in the country, and the prescribers to have ready access for the information about medicines which are available in the country. The National Formulary of India also has very useful annexures towards the end, which you all can refer to. There are 34 chapters in the National Formulary covering about 591 drug monographs. These are again aligned with the national health programs as well as the national list of essential medicines. Only those indications which are approved by the Indian drug regulator CDSCO and found clinically relevant as per the standard treatment are included, and the term availability is now replaced with dosage forms and usual strength. Diabetes again has a special chapter in the National Formulary of India. I would now come to the core strategies to promote rational use of medicines, which you all can use in your settings, in your hospitals, in your healthcare settings. Broadly, we need to follow evidence based standard treatment guidelines. There have to be essential drug lists based on the treatment of choice. The education, again, is a very important part. The education of problem based training in pharmacotherapy in the undergraduate teaching. The drugs which are chosen for the essential drug list, those have to be approved by the drug regulator. Drugs and therapeutics committees in the hospitals play a very important role to promote rational use of medicines, and the continued awareness of doctors, healthcare professionals, and other allied professionals such as nurses, pharmacists, continuing medical education is a very important part to promote the rational use of medicines. So broadly at the policy level, in the country, what is important is that there should be a policy on rational use of medicines. There should be a policy for provision of free medicines to all patients in all facilities. The regulation of the drugs should be enforced in the country. Regular monitoring and evaluation of the programs should be there, and continuous capacity development of healthcare professionals and other health system personnel should happen in the country. At the state level, I would like to highlight, since many of you work at the state level as pharmacists and at other levels, you have to be aware that each and every state in the country has a state essential medicines list, which needs to be again periodically updated, looking at the requirements of the state. The list has to be revised, the obsolete drugs have to be deleted, and the newer drugs which have been included in the national list have to be taken into cognizance for inclusion in the state list also. There is also an essential drug formulary, which is a key part for promoting rational use, standard clinical guidelines, the treatment guidelines, the awareness of these guidelines with the healthcare professionals at the state level is an extremely important part. And the state also has to be mindful that when they look at procurement of medicines for the treatment at the state level, these should be restricted to medicines on the essential medicines list, and favorably they should be generics. So, to reduce the cost and look at the affordability aspects, the procurement should be looking at the essential medicines list criteria and favor the generics. And drug information management system, and again, continued capacity building programs for doctors, pharmacists, nurses are some of the other action points for rational use of medicines at the state level. At the district level, there is a need to continue the training programs and active promotion of rational drug use concept in all health facilities. We should also encourage prescription audit on an annual basis. We should ensure that there are drugs and therapeutic committees at the district level which are established in the districts, which are functioning, which have the SOPs to function and the capacity to function. So if there is a need to augment the capacity of the drugs and therapeutics committees, that should be undertaken at the district level. Continued medical education programs, the CME programs, again play a very important role at the district level. And at the health facility level, what should be mindful of? We have already discussed about drug therapeutic committees, but the orientation of patient groups and engagement with the community, interpersonal communication with patients becomes a very important factor at the level of the health facility to promote the concepts of rational use of medicines. Again, advocacy materials, social marketing of rational use of drugs through mass media campaigns should be considered, to augment the sensitization and awareness of the rational use of medicines concepts at the patient level and the community levels. So, thank you very much for your attention. Antimicrobials are a precious resource, and we really need to work together to preserve this resource. Thank you, and I hope you found the presentation useful.